Hey, this is Michael White. I'm going to give a talk today about precipitous delivery. Sorry for my voice, I got a cold. So how did I come about doing a ER talk about precipitous delivery? Started with COVID. With COVID, at the hospital I was at, the hospital across town closed due to low volumes. That was the hospital that delivered babies, and consequently, all those mothers started coming over to our place. The hospital made a decision that instead of initiating an OB program, that we would stabilize and transfer patients, period. Unfortunately, the OBs in town told their patients not to go to the ER for at least 4 hours once labor started because we would send them home and make them drive themselves there. Consequently, patients were coming in after waiting multiple hours and being in active labor, and they were too dilated to be sent, and consequently, we were having to deliver babies without any OB, any midwives, any pediatric anesthesia, essentially with no help except the ER nurses, not even OB nurses. So I too that picture, that's something my wife puts together for Christmas. You can see how COVID started. The kids were all happy to be at home doing their thing, and then by the end, it was a little bit different story. So this is kind of a detail of what we saw. As you can see, the volume growth over time, and then we got to a point where it went up even further. We were one of the few hospitals to increase during COVID. So this is kind of a diagram of where we were located. We are north central Florida, and the closest receiving was at least 45 minutes away. So lady comes in, she's pregnant, and she says the baby's coming. This was not uncommon. We were delivering 6 to 10 babies per month. So first step is hope your partner takes it. If that doesn't happen, there is a couple different options in terms of how the baby's going to come out. The vast majority of the time, the baby comes out normal. This has been going on since the start of humanity. You can have a nuchal cord, shoulder dystocia, breech, or prolapse cord, and that's what I'm going to talk through today is those different options. If it doesn't, the baby isn't coming out normal. So most of the time with deliveries, it's hurry up and wait. So when you look at this, it takes 5 to 8 hours for the cervix to dilate. And then, it depends on how many babies a mom's had, but it's usually, if it's the first, it's about 45 minutes to come out. If it's second, third, or so on, it's about 20 minutes. And then the placental delivery usually happens 5 minutes after that. So you do have some time once somebody shows up. It's rarely a truly precipitous delivery. When they show up, you want, because you don't know your status and you got to get a cervical check, you want to rapid fire ask questions. You want to know things like any medical problems, if they're on any meds or allergies, and if they know how many babies are coming. Where I was working, it was a poor area, and there was a lot of patients that presented without prenatal care. There's a good portion of these folks that didn't even speak English or a dialect of Spanish that could be translated by the phone translators. So, but if they can tell you that, it's fantastic. You want to look, feel, and try to measure where the baby is at to get a gross idea, and then you want to prepare to catch. And a lot of this prepare to catch part is taken care of by the nurses as they will start getting things together. So with all things, our first key is to do no harm, and please remember that women have been having babies for a long time previous to our medical profession, and the vast majority of time, the mom is able to have the baby without us having to get involved. So obviously introduce yourself, who you are, what's going on, what you plan to do. A lot of the moms where I was located were not happy about delivering in the ER. This is especially true since we couldn't do anything like spinal anesthesia. We could give them a small amount of morphine, but we were not giving a lot because we didn't want the baby to come out with depressed respirations. So you want to do things like get towels and a timer. The timer becomes more important only if you run into problems. And then you want to try to have the right gown on, which should be a fabric of some sort, like a cotton. You want to avoid plastic. Obviously, this is a slippery situation. And if you have plastic, the baby can slip and go where it's not supposed to go. So In delivery, a lot of people in the past had said that mom pushes the entire time through contractions. That's actually not being seen as the most effective way. What she should do is push about 4 times during each contraction for about 10 seconds each. So she would push, take a breath, push, take a breath, push, take a breath, and that helps to have the baby descend more quickly. And then you have the cardinal movements of delivery, which are shown there to the left, and that is the baby as they come down and what they look like. So we'll go to the next slide. So in short, mommy pitches and you catch. And so the baby comes out, you catch, head first, head down right here, and then head up and shoulder out. And of course, you don't want to fumble the baby. That'd be bad. So over 93% of deliveries are uncomplicated. Baby comes out, mom does the work, and we take the credit. Just joking. But if you run into a problem, about 45% of neonates will die within the first 5 minutes if you don't get the baby out. So you do have to plan for the worst. So in doing this presentation, I spoke with a very seasoned OBGYN, probably delivered the most babies in that area in the last 20 or 30 years. And he said he only really gets worried once the head comes out. Once the head comes out, then it's ball game on. And you may recognize from the right there, that's from the movie Aliens, and obviously from the left is a baby whose head has come out. So let's tackle one of the first questions, which is a nuchal cord. This is a baby born in China, and you can see, I believe it was a total of 7 nuchal cords wrapped around, no, 1 nuchal cord wrapped around 7 times. And so you can do a few different things, and we'll go through the math on what's the best approach. But about a third of deliveries have this. You can slide the nuchal cord down over the shoulder or over the head. It depends which one you want to try to do. A lot of people try to go over the head because that seems more intuitive, but the shoulder and getting it over the shoulder and having the shoulder hold it in place is also a very good option. That's what this OB did. And it buys you time, because what you want to do is deliver the baby would be ideal, and you can unwind the baby, so to speak, but you have to get the baby out, which means you have to give the baby time. And remember, once the baby's head's out, the blood flow is diminished because of the location of the cord. Fortunately, multiple wraps of a nuchal cord is extremely uncommon. So if you have a tethered and multiple and you can't do anything with it, you have to make a decision if you want to cut the cord or just spend the time to come out. Either way is not a good decision. It's a tough one to make. If you cut the cord, then the baby's not getting blood flow, and now theoretically the baby's getting strangulated. If you do cut the cord, that does release the tethering, which allows you to deliver the baby if you can get the baby out. Obviously, if you run into a dystocia on top of a nuchal cord, then you have a problem, especially if you cut the cord. Most of the literature I saw recommends not cutting the cord. So let's talk about shoulder dystocia. This is a common thing, a common high-risk thing that you can see. And in short, the idea with shoulder dystocia is, in general, we have, like I started, you have a lot of time to deliver a baby until the head's out, and then you got 5 minutes. And I don't remember if anybody remembers that country song, you got 5 minutes to figure it out, but it's applicable to this. So what we're going to talk about here when we think about shoulder dystocia is the pelvic inlet and the pelvic outlet. So the pelvic outlet obviously is where the baby is coming out, and the pelvic inlet is where the baby's coming in. Now, the problem with the shoulder dystocia is it gets caught up at the pelvic inlet. And you can see the transverse diameter of the pelvic inlet is 5.1 inches. And the AP diameter is 4.3, the oblique is 4.7. And that's going to be very important to know when we're thinking about what we're going to do. And then you can have a couple types of obstructions or shoulder dystocia. You can have unilateral or bilateral, and again, depends on the size of the baby. For if they come into your ER and they know that they have a large baby, then that may help you. By and large, the patients I saw didn't know the size of their baby or the risk. So dystocia, when should you think about this? It's when you see a head pop out and then go back in. It's called the turtle sign. And another option, if it pops out and then it's pinned and not moving. Those are both problems and should make you think about shoulder dystocia. So you want to think about steps you want to do because now you're in an emergent delivery. And as this picture shows up here, the shoulder is caught anteriorly on this. There's the sacrum here behind. So you want to call a code, whatever the hospital code is, to get more resources at bedside, especially if there's another physician that can help you. And you want to start a timer, and I'll go through the reason for the timer a little bit later, but basically keeps you on point. You want to ask the mom to stop pushing, and you need to start doing some stuff to try to get that baby out. So the goals of it are really just thinking about it practically is you want to use the pelvic inlet to allow you to get the baby out. And again, here's that shoulder pinned against the anterior, the pubic symphysis, which it usually gets caught up there. And you want to try to shimmy that shoulder under the symphysis to get the baby to come on out. So there's a couple traditional maneuvers. One is called the McRoberts. The McRoberts is taking the legs and bringing the legs up to the mother's shoulders. Now, one of the keys is you don't want to pry the legs open because that actually narrows the opening of the pelvic inlet. But what it does do is it flattens the sacrum, and so the baby can slide out easier. Here's the sacrum in behind, and the idea is to lower it so that the baby can slide down underneath. Now, there is another maneuver that's called the Reuben, and it is pushing on this area, the suprapubic area, and what you're trying to do is to get the baby down and through. You're going to need assistance to do this. As you saw in the last picture, there were nurses there assisting holding the legs. You can't obviously be doing it all. So here's the Reuben, the McRoberts having the legs up, and you want to do the Reuben as almost a heartbeat or as CPR-like in manner. So you press, release, press, release, press, release. And what you're trying to do is dislodge that shoulder from the pubic symphysis. So about 50% success. So again, you want to think about that. You would like to have your timer set when, as soon as you recognize the turtle sign or the pinning of the head, at about a minute. You can do 45 seconds because you're going to have to transition between maneuvers. But if you start at a minute, and at a minute your use of the Reuben and the McRoberts doesn't work, then you need to move to another maneuver. So the next maneuver class is considered the entry maneuvers, and basically you're going to get in there and try to reposition the baby. So you want to stop the suprapubic pressure, and you want to roll the nose, so to speak. Now, if you remember, and this diagram actually does a pretty good job, that interpelvic ring was widest in the transverse diameter. What you want to do is, here's how the baby's coming out, and you can see that they've taken the baby and they've rotated this baby clockwise. And I'm sorry, my big face is in the way, but this one showed they were rotating it counterclockwise. Basically, you want to roll to the nose. So most people are going to go this way and rotate the shoulder and try to get it unhinged from the pubic symphysis. If it doesn't work, then you go the other direction. So looking at it here, again, here's your shoulder dystocia. Here is where you want to take this axis of the shoulder and you want to shift it over this way. You can try to go the whole way because that'll give you even larger, but that's going to be pretty hard to do it. So rotate the anterior shoulder, so you put your hand inside the vagina, inside that pelvic inlet, and you try to get your fingers in there and you try to push the shoulder over, as this is shown right here. So the nose, feel the wedge to give. As you push it on the shoulder, it rotates, and you'll very often feel that give as the baby releases. So you can do what is called a pop the cork. This is another maneuver, and basically you want to unscrew the baby even further. So if you weren't able to get it with a single shoulder, you put your fingers in there, and again, you don't have a lot of space, but you can put a finger on the anterior portion and a finger on the posterior portion, and you turn like this. That's what's being shown in this picture up here. And what you're doing is rotating the patient from an anterior position of the shoulders to a transverse or lateral position, which will allow the baby to slide on out. And remember, it was a significant amount of extra space you had if you can get the baby to roll. So the next maneuver, again, now remember your clock down at your time. Your next maneuver is to think about posterior shoulder and then the anterior shoulder. So this is trying to actually deliver the shoulders. The shoulders are what's hooking you up. So just to go back, first step, McRoberts and Rubin, and try to get the baby to come out that way. Set your timer for a minute. When it goes off, you want to switch, and you want to switch to trying to rotate the baby. You can try to rotate one direction. It doesn't work. You can try to rotate the other direction. Obviously, if the baby's moving, then things are working during that maneuver. And you can also do the corkscrew maneuver with both fingers in there. If your minute goes off on that one, so now we're at minute number 3, and remember, we got 5 minutes to get this baby out. Then what you can do is deliver the posterior shoulder. And there's a lot of literature, well, actually I shouldn't say a lot. There's literature coming out that's saying this may be your best first move. And what you're trying to do, as this picture shows, is you're trying to get in there to the shoulder itself and push the shoulder, or you get your hand in there and you grab the arm and you pull the arm out. Once you pull the arm out, this reduces the anterior posterior dimension of the baby significantly, and the baby will slide out at that point because you have reduced this diameter right here, which has gotten stuck on the pubic symphysis. And again, it can get stuck on the sacrum as well, but if you're doing the McRoberts properly, this is not typically a problem. But anyways, so they get in there, they grab the arm, they slide the arm out, and then the baby slides out after that. Okay, so let's say that you are now at 5 minutes and you still do not have the baby out. The last maneuver is kind of is flipping them onto all four because it helps with gravity in getting the patient out. And again, you're going to do your rotation and then you're going to deliver your posterior arm, try those maneuvers. But you are at this point doing everything you possibly can. So again, just to overview, you want to recognize and start the timer. You want to reposition the rock and pull, which you're not grabbing the baby's head or anything to pull. We'll talk about that a little bit. And then you want to do your rotation. So recognize 1 minute for that, 1 minute for this, the posterior arm, a minute, rock and roll, and then hopefully at some point the baby will come out. I did ask the OB if there were other options. He said if you're in a precipitous delivery in an ER that does not have surgical capabilities, it is what it is. You can just do what you have to do. As a reminder, when you go to pull the shoulder out or the arm out, that was discussed as maneuver number 4, there's a good chance you're going to break a bone. Usually the humerus of the baby, and that's okay. I mean, nobody wants to do that, obviously, but babies heal well. This is another example. You can fracture the clavicle to try to reduce the AP diameter, and that's to release it. So I clicked by mistake, but the previous slide, it's very hard to break the clavicle. In fact, this OB that I talked to said that he had tried and he wasn't successful. And you got to remember, these bones are very malleable. So the last part is something we were, or at least when I went through, was told never to do, which is to push on the fundus. And actually, there's starting to be evidence that you can push on the fundus to facilitate the baby coming out. Obviously, you want to coordinate this, but just like anything else, it creates pressure up above. However, you want to be very, very careful. For example, if you're trying to reposition a shoulder and rotate a baby, you don't want somebody applying fundal pressure, because that is just going to increase the dystocia for the period of time. So summary of dystocia, 95% resolve within 3 maneuvers. You can do, they talk about doing 30 seconds per position with 30 seconds per maneuver. I honestly think a lot of these happen much quicker than that, especially the rotation maneuvers. And then obviously you never want to twist, yank, jerk the baby, and never pry mom's legs open. And thank goodness I'm not delivering that kind of baby. So let's talk about what happens when you have a breech. So what do you think when the butt comes out first? Well, there's a lot of negative things. If I was looking and I saw a baby coming out, obviously I would be concerned. So when the butt comes out, usually what is going on is the cervix is not fully dilated. And the problem that you run into is the cervix is now functioning like a lasso around the baby's neck and strangulating the baby. We talked about the nuchal cord. This is a different type of nuchal cord. It is a noose of sorts. So of the breech babies, 50% come out with their hips flexed. That's your butt first. Then a small portion with hips and knees flexed, and then there's variable leg position. Either one leg comes out, both legs come out, but that's what you're going to see. So it's going to sound a little bit crazy when we talk about this breech delivery, but one of the keys is to keep your hands off. So mom will push. If the baby's already coming out, you're kind of stuck. Mom will push until the belly button is seen, and then you're going to support the baby. You're not trying to pull on this baby. You can decapitate the baby if you're pulling on the baby, and you don't want to do that. So here's this step. So in this one, you have breech. Both legs are coming out. They are helping with the anterior shoulder, getting around the pubic symphysis, and then you can roll the baby. Once you roll the baby, and remember, we're trying to do that because of the transverse diameter of the inner pelvis will give greater ability. Now, this last part over here is crazy. So you've delivered both shoulders, the baby is still stuck. The recommendation is you leave the baby hanging there for a period of time. You want to direct the nose of the baby towards posterior, and just wait. And a lot of times the cervix will relax enough that you can get the baby out. If the baby isn't coming out, and again, you have your 5 minutes, so let's say that you already a minute into this, then you wait for 36 seconds, which will probably be the longest 30 seconds of your life. Then you can try this approach. You see on the one hand, the baby or the practitioner is coming in, has the hands over the shoulder, and is coming up here with the other fingers trying to get into the mouth. And up here is almost like the Rubin maneuver. You're applying pressure to be able to push the baby down and out. So you want the fingers to the maxillary process. You want to flex the head down towards the chest, and you want to apply gentle traction to the shoulders. Again, you are not trying to do severe pressure here, or you're going to have problems with that. And then the suprapubic pressure, and remember, this could be a dystocia, but this also could be related to the cervix itself and that noose. So if you get to the point, you can do extreme measures. What's an extreme measure? That's cutting the cervix. Again, that's going to be very hard to do. You're going to have limited visibility in what you can do, but you want to think about cutting at 10 after the hour and 20 after the hour to be able to release the cervix, to be able to get in there. And remember, the cervix is a relatively long structure. So prolapse cord, you go and you see that the umbilical cord is hanging out. The problem is that right in here you can get diminished blood flow because the cord gets compressed. So this situation needs a C-section unless the baby's suddenly going to just come out, but there is some stuff that you can do. Gravity is your friend, so here's a prolapse cord hanging out. And if you get mom on all fours, what that does is it can drop the baby down, which releases the pressure on that cord. So gravity is your friend in that situation. All right, let's just talk about postpartum problems, and we'll just do this briefly. But the baby came out, everybody's happy. But then the mom starts exsanguinating. So one of the very common things is you want to find the bleeder. Very often they can have tears in the genital urinary tract, and you want to find that. Another option is retained products, especially if somebody was overly aggressive trying to pull on the placenta to get it out. If it's mom that's had a bunch of babies, she can have a uterine inversion where the uterus is literally coming out. So you want to look first for the genital tract trauma. If you have a cut there, you can tie it off, do a quick stitch. If it is retained products, you're going to have to put your hand inside the uterus to try to identify if that's there. It's not going to be comfortable for mom, but you got to do it. And then you need to, obviously, before you stick your hand in to find if there's retained products, you should see if there's a uterine inversion, which will not be very subtle. Here's an example of a uterine inversion. The uterus is out. You put your hand in and push it back in. It's not rocket science. It's just practicality of how you do it. But once you do that, you're going to want to maintain uterine pressure, both with things such as oxytocin as well as manual pushing down the suprapubic area. So uterine, let's say that it's bleeding because it's just postpartum bleeding. It's not, so you didn't find a laceration, you don't have retained products, it wasn't an inversion, but they're continuing to bleed. So uterine massage is your key, which is suprapubic. There's a image on the next slide of this, and then you want to get your oxytocin going to try to get that uterus to clamp down. Remember, the uterus is a muscle, and the oxytocin helps that muscle contract. Here's an example of mechanical pressure, one through the vagina and then the suprapubic, and what you're doing is pinning those together because there's bleeding going on within there. Another option is, this is a bag, obviously, that's a towel, that's gauze, and it's a lot of 4-inch gauze. You put it inside there, and then you use saline or similar to fill this up with water, and you're holding pressure here, trying to get pressure inside there to stop the bleeding from going on. So meconium, when a baby comes out, people worry about meconium staining, and there's good reason for that. However, for us, very often it is just a little bit of patience. You can suction the baby. You don't have to go directly to intubation. You need to see how the baby's doing. It's okay to be blue at birth. It's normal-ish to be 60% pulse ox at 60 seconds after delivery, and then you can have hypoxia up to 10 minutes afterwards. So just don't jump to oxygen. See how the baby does over time. And so I wanted to thank you for your time, and hopefully this was useful to everybody.